Hello and welcome. I'm Kim Meredith, CEO of the San Francisco General Hospital Foundation, and I am delighted to welcome all of you here today to hear in this briefing innovations in public health about Solid Start. So at the Foundation, we believe that everyone deserves access to excellent health care, and our mission is to fund and support patient care and innovation at Zuckerberg San Francisco General Hospital and Trauma Center. We do this because we believe in equity and access and healthcare for all. So through our grant making and program support, we invest in programs built on the pillars of innovation and equity, giving way to new models of care, such as Solid Start. And it's exactly programs like Solid Start, which you will hear about today, that exist because of our shared commitment to health equity. As a supporter of the Foundation, you enable the life-changing work that we are able to support every day, day in and day out at ZSFG, during everyday issues, challenging times, and in times of crisis. Thank you. Today, we are honored to have special guests and experts from Solid Start. We will hear directly from Dr. Malini Nijagal, an OBGYN at ZSFG, Solid Start lead for the perinatal financing and sustainability, and co-leader of the San Francisco Pregnancy and Family Pop-Up Village. You will also hear from Dr. Melanie Thomas, a perinatal psychiatrist and director of Solid Start. Additionally, we have an audio recording from Maisha Jones, the perinatal health coordinator for Solid Start, who's associated with the Homeless Prenatal Program. So with that, Solid Start started in 2015 with seed funding and support from the Foundation. Our goal was to help improve the health and well-being of pregnant people, infants, and children, and their families. Starting with an in-depth evaluation of the current systems in place, the team found that there was often a siloed network of providers through the city that actually created barriers to care. So we know pregnancy, birth, and the early months of a child's life are often informed and complicated by societal, environmental, and behavioral factors that will impact them for the rest of their lives. So with that, let's start with Dr. Thomas. I'll begin by asking you how the Solid Start initiative promotes a level playing field and strong scaffolding for these pregnant individuals and their young families. Dr. Thomas.
Good morning, and thank you so much, Kim, and the support of the Foundation and other donors and philanthropy in general has really been invaluable. And it's great just to hear a little bit about or share a little bit about our experience today. So in terms of how Solid Start operates, just to give a little bit more background in addition to what Kim already shared, our approach is first and foremost to be family-centered and respectful in our approach to delivering trauma-informed care. And what that means is that no one size fits all, and we make a really strong effort to meet our families where they are, whether that's in their prenatal visit, first at the point of delivery, or out in the community. And we'll share some more examples about how that works. We work really closely with 5 primary clinics on campus at ZSFG. Those clinics that we work most closely with are the Obstetrics, Midwifery, and Gynecology Clinic, our Children's Health Center, our Family Health Center, and our Birth Center. As Kim mentioned, one of the big problems with prenatal, postpartum, and early pediatric care are the silos that our healthcare system creates. And so our goal with Solid Start is to work across those silos by embedding a unique workforce, specifically community health workers, who can navigate across silos and follow patients where they go instead of being tied to a specific clinic. Another key component of Solid Start is to partner outside of our hospital. So San Francisco is a very rich resource city, but many of those resources, as Kim mentioned, can be fragmented. And so what we do with Solid Start is we work across DPH and some key CBO partners to really work with our pregnant people and families with young children, and to work with our groups so that we don't duplicate services and that we can more effectively serve more people. So to give a concrete example of how this works, and specifically to hear from one of our community health workers, I'm going to play an audio from our friend and colleague who works at Homeless Prenatal Program and with us at Solid Start, Miss Maisha Jones. I'm going to play this now.
I want to share just one of many memorable and impactful stories that I feel encompasses why we do what we do and why these collaborations truly work. Jenny and I were fortunate to meet with a mom-to-be about 2 or so weeks ago here in the 5M clinic. We were briefed ahead of time that this mom and her husband started out on a journey from Guatemala in hopes of ending up in the US to live that American dream, so to speak. Well, things definitely did not go as planned. Mom and dad were detained at the border with no clue as to what was going to happen to them from that point on. Now, fast forward 3 months later, they're still being detained. Mom has had no prenatal care. She was about 4 or 5 months pregnant at the time. And they were still not certain about what was going to happen to them, what was their future. They had no idea. But nevertheless, they were still hopeful. So the time came when mom got the news that you can continue on. What a relief, right? Well, mom could continue on, but dad was told that you will not be leaving today. And when you do leave, it will not be to the US. So in that moment, I can't even imagine what must have been going through what they were feeling, or what she was feeling, like how hopeless, or just not knowing what the next steps would be. But even though she knew that if she continued on alone, she would not know where to go. She wouldn't know the language of the place she would end up, resources, where she would sleep. I mean, just none of these things. So she would have absolutely nothing, except one thing: she still had hope. So she was hopeful that if she made it here, things would get better for her and her family. So when we finally met face to face with this mom, I had already thought about how incredibly strong she was and must have been, but I also felt she was probably going to be really vulnerable and scared and lost too, coming into this meeting. So it definitely took time to peel back the layers of trauma and mistrust, and just her really trying to process what she was going to do. But when we finally did make a breakthrough, it was like pure magic. It truly was. We were able to connect her to many of the resources that she needed the support with. And so some of these things included, but not limited to, housing resources, gift cards for food, clothing for her and her baby to be, therapy, case management, immigration support, just to name a few. So the other day on March 7th, I believe, mom gave birth to her baby boy. And Jenny was right there with her. She visited with her yesterday for more than 2 hours. And today I will accompany Jenny on a visit. Now that I'm saying that out loud, it sounds a little stalkerish, but we really just want to let her know that we're there for her. So yeah, these are the things, like these are the reasons that we do this work. And we want her to know that we're here for her. We see her, she's safe, and we got her. So this is the work that I believe will start the healing in ourselves, our community, and then ultimately the world. So I'm super hopeful.
Thank you, Melanie, for sharing that audio recording of Ms. Maisha Jones. I think that is so powerful, how Solid Start is changing people's lives for the better. And I think for our visitors here today, 92% of patients at ZSFG are on Medi-Cal, Medicare, new immigrants, uninsured. And so these stories are who are treated every day to the incredible care that people like Dr. Thomas and Dr. Nijigal give to our communities. So thank you for sharing that. It's very, very powerful. I think all of us can reflect back, either as a mother, a daughter, a sister, a cousin, on how overwhelming that would be to come to this country. So when we think about that story, Dr. Nijigal, and we think about Solid Start's role to kind of move away intentionally from traditional models of healthcare to meeting people where they are. Tell us about the work that you've been doing out there in the community with your pregnancy pop-up and other work.
Thank you, Kim, and thank you so much for having me. Yeah, I mean, I think community is the key word there. And I think that Solid Start is, it's such a core part of how we're trying to shift from kind of the more traditional model of healthcare that exists in the United States to one that is truly community-based. And I think, when we think about community, a community-based approach and what that means, we really approach that and implement it on from a few different angles. So one is around the people. We think a lot about in traditional models of care, there's often a lot of separation between those of us who are providing the care and those who are receiving. And especially at a place like San Francisco General, like Kim, you just pointed out, so many people are facing really significant socioeconomic and other barriers to care. So this difference becomes really key. And so when we think about being more community focused in the people that we have, we think about our integration of community health workers like Maisha, who you just heard speak. We also support and develop programs like Black-centered care, where we think about our providers in our care team being racially concordant with the people that we are serving. The other aspect of being community-based, Melanie, Dr. Thomas mentioned earlier, which is around community-based in our partnerships, right? So how are we, clearly the medical services that we provide at San Francisco General and the clinics are absolutely critical for people's health. And there's so many other types of services that are critical for people's health, which in the traditional approach to healthcare, there was no place for. The things that Maisha just talked about, the food access, safe housing, violence in communities, support for all of these things that absolutely impact people's health. But again, we often do not have the tools within our hospitals and clinics to be able to do all of it. So community-based partnership is a really critical piece that we believe in. And then finally, place. And I think this is what you were alluding to or speaking about, Kim, which is we really think about community-based, place-based approaches to supporting people's health. So what does this mean? This means that, of course, we are here in the hospital and the clinic to serve people who need us here. And we really need to be out in their communities, supporting them where they're living, and they're getting that they struggle with a lot of the threats to their health. So we do that in a couple of different ways. Again, we mentioned community health workers. Many of you may have heard of community health workers. It's a very common model. Often community health workers are actually just placed within the clinic and that's it. And what we do at Solid Start is we've really thought about, yes, we want the community health workers to be within the clinic because people come into the clinic and that's where they can connect. But we really need our community health workers to go back into the community and help people with whatever needs they might have, including just navigating all of the different healthcare services that they may need to get, which may not be on campus. And then finally, the place-based approach, the San Francisco Pregnancy and Family Pop-Up Village. So this is another example. where this is a monthly event. It's like a block party type event that we hold in community. And what it does is it brings together multiple organizations that include community-based organizations, the kind of city government services, so the social sector, the public health sector, as well as our clinical care. And then we have services spanning from like haircuts to classes to food demonstrations. And what it provides is a community-based one-stop shop that really allows people to support their own kind of comprehensive health and wellness needs, but in a way that's very integrated and really, again, is coming to them and their communities and is culturally and community relevant in a way that sometimes can be difficult in the hospital.
Thank you. Such impactful work. Thank you for sharing that, Dr. Nijagal. Let's take a look at who all is benefiting, both sort of within the context of the clinic, but also, as you said, kind of with the community-based work that's going on. I think for those of you who might be newer to our work, ZSFG serves 20% of San Franciscans all the time, and it was up to 30% during COVID. We also have the largest pediatric clinic in the city there. So this is a really important part of that work when you look at the puzzle of who needs care in San Francisco. So Dr. Thomas, can you give us an idea of the number of prenatal patients, families with young children that Solid Start attends to annually, and the impact that the program has on their lives as they move from birth into well baby care and healthy steps and such. So you're a big part of that important continuum for these young families.
Yes, I'm happy to speak to those numbers and the prevention and the intervention services that we offer. So annually, Solid Start touches around 600 prenatal patients, and that's inclusive of all of our patients in the 5M clinic, Team Lily wraparound services for substance use disorder, and Malini also alluded to an emerging model of care that's really centered on people who are Black identified, including group prenatal care for those folks as well. And then we have about 1,200 births annually at our hospital. So you'll notice the discrepancy between 700 and 1,200. There are people who deliver at San Francisco General who receive their prenatal care out in the community clinics and not with us on campus, but they still come to us for that birth, which is another important opportunity for them to engage with our team members, our social workers, our mental health clinicians, and often our community health workers as well. And in terms of young children, Kim mentioned that we do have one of the largest pediatric clinics. We serve about 3,000 families each year in the age range of 0 to 3. And so, it is a large number of pregnant people, people who deliver, and then young families that we are able to impact through Solid Start. And what I love about the Solid Start model is that our mission is broad, going back to meeting people where they are. So the umbrella of services can be anywhere from, basic prevention. You heard the story about connecting people with food and housing and really addressing some of those social determinants of health, all the way to more intensive wraparound services, such as the Team Lily model of care, and also that close partnership that we have with a number of community-based organizations, whether that's our Sister Web Doula program, the homeless prenatal program, our public health nurses that live with the Department of Public Health, and the pop-up village. So the vision is really to have that web of services that people can connect to wherever they are, that idea of no wrong door, right? So if someone comes to us at the hospital, we want to make sure they know about pop-up and they know about homeless prenatal and they know about these other services. If someone comes to pop-up, we want to make sure that they know about services at the hospital and out in the community. So I think that's really the biggest example of our impact, Kim, is that community partnership and being able to follow people wherever they go. I think another important thing to highlight is that really tight connection that we have with programs like the homeless prenatal program. Aisha gave some detail about those services, but the access to the housing allocations and food, car seats, all of those things that sometimes our families come to us without having any connection to our city. For us to be able to provide that connection is really what we do. And then finally, Malini, Dr. Nijigal alluded a little bit to racial congruent models of care, and that really is an area of growth for us in Solid Start. We know that many of our families identify as Black or Brown, a huge number of monolingual Spanish speakers. So we're working really hard to create a workforce, whether it be with community health workers or mental health providers that look like the patients we serve and are able to have both linguistic and racial congruence wherever possible, to break down some of that sense of distrust that exists with the healthcare system and to rebuild the sense of trust with our community.
Thank you, Dr. Thomas. That was very comprehensive. Your description of the needs of the families that you're serving really tells a story of what is going on with Solid Start and how you're really impacting these lives. We know that just on a general basis, about 1 in 6 of the folks coming into ZSFG are food insecure, 1 in 4 housing insecure, and it's even higher, I think, in the population that you're working with, and those obviously with the homeless prenatal programs. So this is really important work to keep our families, young families, safe as they move into the world here in San Francisco. So with that, the foundation has supported actively all of the work of Solid Start since 2015. But other folks are starting to recognize the importance of this work. In fact, the state of California is now realizing that the level of an exposure to trauma, violence, racism is actually a public health crisis. So Dr. Nijigal, how is this playing out in terms of some changing policies at the state level, and how might that affect Solid Start as we look ahead?
Well, as someone who focuses on making new models of care sustainable, what's been happening at the state level with regard to payment and policy has been incredibly exciting over the last few years. In a nutshell, the big shift is that what the state feels qualifies as healthcare, in other words, what our state Medicaid program or Medi-Cal will pay for, and who it will pay to provide it has really dramatically changed. So most of these changes come from a program called CalAIM, and people may be reading about that in various spaces, including in the lay press. CalAIM stands for California Advancing and Innovating Medi-Cal. And this launched in January 2022, so we're just in the second year of it. But this is a set of reforms that really focuses on making care more accessible, more seamless, and patient-centered, and really focusing on how to tackle health inequities. And the exciting thing about this is just at the same time as they've been rolling out this CalAIM with again, payment and policy reforms, they also have come up with a comprehensive quality strategy. And they chose 3 core areas to focus on. And they happen to be the 3 core areas of Solid Start. So maternal health and birth equity, child preventative care, and behavioral health integration. So we're in a great spot. We're very excited. So what does this mean really tangibly? What does it mean that Medi-Cal is now paying for things that previously were not considered healthcare? Things like care managers, people having access to a person who is really going to coordinate all of their needs and is kind of assigned, it's their personal person that they can access. That has not been paid for in the same way in the past. They are paying for things like meals, medically tailored meals for people who have chronic illness, or even people who have things like in the pregnancy world, gestational diabetes, right? Where somebody actually gets payment and a lot of support around being able to prepare meals that will be consistent with what their dietary needs are. They're paying for things like short-term housing after hospitalization. There's a whole slew of what they're calling a community supports under one of their programs of CalAIM, which again is really novel and groundbreaking. So I think, you know, what's interesting here, of course, is as a philanthropically funded initiative with Solid Start, we've always had the opportunity to create these incredibly novel and person-centered models of care in collaboration with the pregnant people and the families we serve. And now we're getting this amazing opportunity to figure out how to make them sustainable. And that is incredibly exciting. And the last thing I'll say about that is, for me, what has been awesome, amazing, is that we've really been able to contribute and benefit in a bi-directional way with the state. So of course our programs are benefiting because now the care that we were providing, it's getting paid for. So that is certainly helpful. But the great thing too is the state has also been really deeply engaging us in helping them design the new benefits and policies, because they're aware that we've been doing this kind of work on the ground for a number of years. And they know that we're focusing on the populations that they are trying to design their benefits and payment for. So we've been really integrated with that and integral to that work, and the learning has been tremendous, and it does really feel like a once in several decades opportunity to really change what's happening on a much broader level than even in our local community.
Thank you. That is such good news. And I think the combination of ongoing philanthropy and public funds and that public-private partnership can really move this initiative forward and help it scale and do more outreach and more work more broadly for this community of young families. So thank you. That is very exciting. I'm going to ask all of you in the audience to start thinking about your questions for Dr. Nijagal and Dr. Thomas, and put them into the Q&A while I ask Dr. Thomas the last question that I have for her before all of you start digging in. So with that, Dr. Thomas, in terms of opportunities and next steps, what's on the horizon as you look ahead for Solid Start?
As Malini, Dr. Nijagal just alluded to, it is a very exciting time. It also feels a little bit like a roller coaster, I'll be honest. You know, it's not, we're still coming out or in whatever phase of pandemic era we're in. So to have, you know, been on the ride with Solid Start and our institution through that public health crisis, and now in 2023 to have this opportunity that does feel like once in a generation to work with the state and scale and really enhance perinatal and postpartum care is amazing. So I feel like where we are with Solid Start and where we're headed is this very unique and exciting opportunity to take the grassroots, deep community-based work that we've been doing for a while, and even before Solid Start existed, that was happening at ZSFG just by nature of its community roots and being a safety net institution. And to utilize this framework that the state is now giving us to highlight and extend and expand and sustain this grassroots community-based approach. It is a large implementation lift. So, you know, I have never been in the weeds of taking state policy and trying to fit or not fit or shift whatever it is we're doing on the ground to align with this amazing opportunity that the state is giving us. So where we're headed is exactly that, right? We recognize that we are being given this very unique opportunity to work with our community partners, what we've been doing on the ground, and to work at the state level to fit it together, right? To be a broker, so to speak, between the community organization and the community that we serve and the safety net, the state policy, and how does it really fit together? So it's really the definition, I think, of innovation and implementation. And I feel incredibly fortunate to have the relationships and the colleagues that I do, and the support of the foundation and the philanthropy that we will continue to need to play in this space with the state. Just to brag on us a little bit, we had the state of California, the Department of Healthcare Services, come and visit us at ZSFG just last month, particularly looking at our prenatal, perinatal programs like Team Lily and Solid Start. And they really want to engage with us, as Malini said. There will be follow-up meetings. They want us to be potentially in their technical assistance marketplace, to be leading other programs at the state. So these are all things that we're looking at in terms of what's on the horizon for Solid Start. A little bit more concretely for our patients, what's on the horizon, I would say, is really just continuing to grow and do what we've been doing, right? We want to expand our community health worker workforce. We have an opportunity now through CalAIM that more of our patients will officially qualify for care management, and we want to be able to provide that service with community health workers. And so growing that workforce in partnership with homeless prenatal programs, Sister Web doula program, and figuring out how we bring as many of those services onto our campus as we can is what we're going to be doing. So I think we have a lot of exciting things on the horizon, and it's a really interesting time. And it feels like a privilege to be working in this space and at ZSFG in this moment.
Mm-hmm. Thank you, Dr. Thomas, for that very exciting look ahead. I mean, what a great example of taking policy and turning that into action to innovate and improve patient care. So that really speaks so well for all the work you're doing. And it's exciting to know also that you are being looked at as a leader within the state with this program. So congratulations to you and to Dr. Nijagal. So with that, I have some questions that are popping into the Q&A that I'm going to take a look at here. So the first question is, why is enhanced care management implementation critical for the Solid Start mission? And what services does enhanced care management offer? So which of you would like to take that question, that first question?
Yeah, so I mentioned this when I was talking about CalAIM. One of the core benefits and programs of CalAIM that has already been rolled out is called Enhanced Care Management, the acronym being ECM. And it was what I was sharing about people who qualify for ECM having a lead care manager. And what that means is that this person is paid to do care management. Now, what is so critical to this and what is so new about this compared to other benefits that we've had in the past is that this payment can come to us, to our care managers, for things that we are not doing directly with the patient. And I think this is a really critical, your question about like, why is this so critical for Solid Start? Because we have so many patients that have really complex needs. And of course, there's a lot of face-to-face connection that we need to have with them. And then there's so much that we need to do behind the scenes when they are not with us. And traditionally, we were never paid for any of that work. So you can imagine the more complex your patients are, and the more patients who are complex and the more complexity of each patient, the more number of hours and number of people you need to be able to provide care that is really person-centered and is going to be coordinated. And that's what enhanced care management is allowing us to do. So the specific services, again, there's a whole list of what the lead care, what they call the lead care manager can do, but it really is anything from going to care coordination meetings to being on the phone, literally coordinating people's housing if they need it or whatever else, to actually directly, you know, making a call to the patient or seeing the patient doing. So it really is an incredibly flexible, it's an incredibly flexible program, but a model of payment, again, that really supports the work that we have always known is critical to provide excellent care.
And just to add to that, what I think is wonderful about ECM is, I mentioned earlier this sort of the feeling like the state is giving us a framework. So in order to qualify for ECM, people need to meet certain eligibility criteria, but the criteria for our pregnant people and families with young children is exactly some of the population that we're already serving. So to give people an example, it's pregnant and postpartum individuals with severe mental illness or substance use disorder, all pregnant people and families who are experiencing homelessness, children who are involved in child welfare or who have developmental delay. And then finally, starting January the 1st, the state is rolling out their birth equity population of focus, which will extend the benefit of ECM to all Black identified individuals across the state of California. So it is a really powerful move by the state, I think, to recognize the intensity of coordination and services that is needed to serve this complex population.
Thank you. So I think everyone can see the complexity that's going on and the need for this enhanced care management. So some other questions that have popped in now relate to infant mortality rates. And so very specifically, just maybe you can talk overall what you know in the Bay Area, but then more specifically, is there a large disparity in the infant mortality rate between white infants and infants of color? And I would also add to maternal mortality also. So if you can speak to that very broad topic and kind of the broader numbers and then bring it down into some of the specifics that we are engaged in and you are engaged in at ZSFG and Solid Start.
Yes, so absolutely, infant mortality and maternal mortality countrywide and in San Francisco, there absolutely are racial inequities, disparities in those rates. I will say maternal mortality is a very rare outcome. And so it's a little bit, in any one city, it's always hard to exactly see which direction you're going in, but there's no question that the disparity, even though California's rate of maternal mortality actually has gone down over the last 10 years, the disparity, the racial disparity persists exactly the same as it was all these years. So we do see that. I think, if the question really around what does that, how do you tackle that? And I think particularly this gets into the much deeper questions of why do these inequities exist in the first place? And what we know is that they are tied to racism. So they're tied to all forms of racism. But when we think about what that means in terms of systemic racism, it really goes back to the things we've already talked about today, that the impact of systemic racism is that families and pregnant people don't have the opportunity to be healthy, right? They have not had they've not had safe places to live. They do not have access to healthy food. They are exposed to violence. They have not, in many cases, often, especially if they've come from other areas, they have not had access to healthcare earlier in their life. So they are entering pregnancy in a way that is not optimal. And these factors absolutely set up for both infant mortality and maternal mortality. Infant mortality, a large portion of it is around preterm birth. So again, we think about all of those factors that may lead to preterm birth, which do include medical conditions and just general health. Again, going back to the issue of the opportunity for health. And then on the infant mortality side, on the maternal mortality side, again, a lot of morbidity that people, they're basically the same thing, but the preterm birth issue and maternal mortality both really stem from the kinds of opportunities people have for health before they get pregnant, and then what is happening during pregnancy. These are definitely not easy fixes. Nobody has figured out any specific interventions to close this racial gap in the rates that we're seeing. And so we know from that we really do have to tackle the root causes, which gets back again to the things we've discussed today.
Dr. Thomas, is there anything that you would like to add to that? I know overall at ZSFG, the patient population, it's about 37% Hispanic, Latinx, 22% Asian, and 15% Black African American. Does that represent what you see in your population, or is it a different group?
I think it's a little bit different. The pregnant population at ZSFG is more like 55 or 60% Latina identified. And then I believe after that, although Malini, you might know better than me, it breaks down pretty evenly among the rest of sort of the more traditional racial groups that we look at, Black, white, Asian. I think, going back a little bit to this question of mortality and what contributes to that, I definitely would agree with everything that Dr. Nijikal said about the underlying causes. As a psychiatrist, as a mental health provider, I'm pretty aware of the chronic trauma, the childhood trauma, the ongoing trauma that many of our patients have experienced. And that also can lead to preterm birth. It also, of course, can be associated with not so healthy coping behaviors, whether that's, substance use in particular. And substance use is a really large problem in our city right now. I mean, people are seeing the headlines. And so that intersection, I think, of poverty and racism and trauma and how those factors all unfortunately work together to contribute to infant and maternal mortality is really the reason why we think about broad interventions like community health workers out in the community, and also giving people opportunity. I'm really proud of our community health worker program. We're serving now as an intern site for the homeless prenatal program. And many of these women who work with us now have themselves experienced preterm birth or other struggles during their pregnancy and postpartum. And so it does feel like moving beyond our traditional interventions that we can provide as doctors, but to be able to really elevate that relationship-focused care and community-focused care, while it's not going to close those disparity gaps in one generation, it is clearly the longer path toward the social justice and equity that we're all hoping for.
Thank you. That actually leads into another question that has come up. Where do you see expansion with community partners to better meet the needs of the families that you're serving? Are there areas that need more services, more community partners? So where are the two of you on that?
Yeah, I mean, it's a great question. So, when I first started working in San Francisco, what I was so struck by was just the number of organizations. I mean, as Melanie said earlier, we are such a resource-rich community, and we see that in our community-based organizations as well. I think my answer would be no, I don't think we have all the connections. I think we have spent a lot of time understanding who's around and building those relationships. But what is really, really time consuming and is, for the long haul is relationship building. Because the question is like, what does it mean to be really working with and to be connected? And that answer has to be based on what we are working around. So what does it mean to partner with specific community-based organization to better meet the needs of our joint client patient? And that's a much different question than like having meetings where we put everyone around the table together and get to know each other. We need to really like invest into understanding, number one, what are the issues together? And number two, how do we work together? So I would say, this is one of the things that I've really appreciated at about Pop-Up Village, for example. One of the things that COVID took away from us is just human interaction between each other. So it used to be if we all came to a meeting, after the meeting, we would all kind of hang out, you get to know people a little bit, you start brainstorming about issues, you build connections. That has largely gone away because Zoom meetings, you log on, you talk about the issue at hand and you go away. And so there is a lot more time needed to invest into those relationships and the brainstorming about how we can make our systems and our partnerships better. And Pop-Up Village has really allowed us to do that because there is this one time a month that is open to everybody. And we're really, as long as the mission, we don't have requirements about who you need to be a part of it outside of just having the same mission and focus population. And because of that, what we're seeing is a lot of these kind of new opportunities for collaboration and brainstorming. But honestly, I think this is a lifelong partnership and relationship building and trust building, and should be a constant part of our work. It'll never be over.
Thank you, Dr. Nijigal. So I'm going to ask my final question, and Mel and Dr. Thomas, you might want to start, and then I'm going to ask each of you for your the last word that you want to impart with this group. And Dr. Nijigal, you may want to jump in on this also. We heard from Ms. Maisha Jones about her work in a very specific case, working with an asylum seeker who came to our city, a new immigrant without resources. Can you talk about how Solid Start works with early intervention, how you get connected to these people, and then just share a little bit more about what that might look like? And maybe you each have a story to tell. So how Solid Start works with early intervention.
Let me jump in, and I can try to also think about a story as I go. I mean, early intervention is the reason that Solid Start exists. We have a lot of science showing us the return on investment and the significance from a public health and health outcome standpoint of the early life. So, we're all about the early intervention. One of the great benefits of being at ZSFG, where we have prenatal care and a birth center and a pediatric clinic, is we can jump in at any of those moments in time. And that is the way that Solid Start is designed, right? We hope to get people to interact with families as early as possible on that spectrum. And, I have been known to say that before every baby, there is a pregnant person. So I do feel that, our opportunity to intervene in prenatal care and carry that continuity forward across the birth divide into the pediatric care is part of what makes Solid Start very unique, right? We don't have to be siloed by maternity care or pediatric care. We have the gift, because we have all this messy space on our campus with these multiple clinics and these community partners, to be able to intervene all along that spectrum. Really, and one of the things that I love is, more and more as we have more community health workers in different spaces with us, what happens a lot of times is somebody will meet them during pregnancy, and then they'll show up, same family, a year later in the pediatric clinic, and we're able to reconnect back to that same community health worker to promote that sense of relationship, which I think is such an important part of how we build trust and how we build continuity. I think the story that I'll tell is, if I'm trying and looking for a story right now, would be one that is kind of con- a mix of how people can move from our different programs and what that can mean for our families. So, this is a family, and a young single woman who came to us not very long before pregnancy or before she delivered, pretty late in her pregnancy, and initially was homeless and also using substances, and initially connected with Team Lily. And unfortunately for her, at the time of her delivery, she wasn't far enough along in her recovery journey to immediately go home with her infant. However, she did go to a treatment program that we helped to connect her with. And she also then got connected with a Black identified mental health clinician who is specifically trained to provide dyadic mental health services, meaning services that are focused on not just the mom, but the mom and the baby together, and has been able to support this dyad through the reunification process. And so this is a story with a happy ending, because I just saw this mom and her baby in the office last week. Her baby is now 8 months old. They are reunified and living together, and still working with that same therapist that we were able to connect her with probably 6 months ago now. And so I think this is the power of I guess it's early intervention, but also not being tied to a particular moment in time, but being able to intervene whenever possible and then follow across the journey, right? And so that's a story that I would share.
Thank you. That's really powerful. And I would say definitely early intervention, birth to 8 months. So a very good story. Dr. Nishagal, is there anything you want to add there?
No, that was great.
Okay,
Nothing to
thank
add.
you.
Thank you.
Well, then at this time, there are no other questions. So I am going to ask if either one of you would like to have a final word, any last minute comment or thought that you want to share to, um, you know, bring forth any additional thoughts around what you're doing in the community, how you're translating policy into action, or any of the other work that you're doing you'd like to share before we thank our participants and close the event.
Yeah, nothing groundbreaking, just a lot of appreciation for having me here today, and certainly with the foundation and its supporters and the supporters of our work. As I mentioned before, it's never been so clear to me like how important that is when we are in this moment. And as I mentioned, with everything happening at the state level and the amount of attention that is now being given to the things that we've been doing for so long, it's so clear to me that when we have this kind of philanthropic support and foundation support, we're able to be ahead of the game. And then we can, and we can implement these things, but we can really, again, just amplify our impact as soon as, the state catches up with us. So I really just have a lot of appreciation and thank you all.
Thank
Yeah,
you.
I would just echo that gratitude. It is very, very meaningful and a real privilege to work where we work and to work with the patients and the population that we serve and in the community. And I really can't imagine working anywhere else. And the philanthropic support of the foundation is a huge part of that, as is the vision of DPH and the hospital leadership. And so, I think the history of Solid Start really tells that story so beautifully of what can happen in the private public sector. And it's a real gift to be involved in that. And, Malini and I love to talk about these things and are sort of joined at the hip in a good way around it. So, if anybody listening to us wants to hear more, you know where to find us, I hope. And we would be happy to do an even more in-depth conversation about any aspects of the work.
Wonderful. Thank you, Dr. Thomas. Thank you, Dr. Nijagal. And thank you to all of the participants today. Philanthropy is society's strategic risk capital, and it is that capital that gives us the opportunity to do our grant making to incredible programs such as this. So I want to thank all of you for your support, and just know that it is going to support patient care and innovation at ZSFG. And today, you just heard a beautiful example of that. So I wish you all a great day. Gratitude to each of you. And again, thank you to our experts. Have a wonderful day. Take care.